I want to welcome all of you to the 2018 Robert S. Gordon Jr. Lecture in Epidemiology. My name is David Murray. I'm the Associate Director for Prevention here at NIH and also the Director of the Office of Disease Prevention. I'm pleased to represent Dr. Collins today to tell you about the Robert S. Gordon Jr. Lecture and introduce our speaker. Before I do that, I want to let everybody know that there will be time for questions after the presentation. There are microphones in each of the aisles, and I know that they're working because I was here when they were tested. I would also like to invite you to join me at a reception for our speaker in the library, just off to my left, after the presentation. Let me tell you a little bit about the Gordon Lecture Award. Robert S. Gordon Jr. Lecture is awarded each year to a scientist who's made major contributions to researcher training in the field of epidemiology or in the conduct of clinical trials. The Gordon Lecture recipient is selected based on the recommendation of the NIH Epidemiology and Clinical Trials Interest Group. This is the 24th year that the Office of Disease Prevention has sponsored the Gordon Lecture. The list of prominent scientists who have previously been recognized and received this award can be found on our office's website, prevention.nih.gov. The Gordon Lecture was established in tribute to Robert S. Gordon Jr. for his dedication to the field of epidemiology and his distinguished service to NIH. Over the course of 30 years, Dr. Gordon served in numerous senior leadership positions, including Special Assistant to the Director, Chief Advisor for Clinical Practice and Research. He was an early organizer of efforts to address the emerging problem of HIV and AIDS and became a key coordinator of AIDS research at NIH. For the last 10 years of his service while working here at NIH, he made important contributions to policy and management issues regarding epidemiology, clinical trials, and the health effects of environmental hazards. Today's speaker, Dr. Ana Diez Roux, received her MD from the University of Buenos Aires in 1985 and an MPH in epidemiology from the Johns Hopkins School of Hygiene and Public Health in 1991. She earned her PhD in health policy and management in 1995, also from Johns Hopkins. She began her academic career a little further north at Columbia University in 1996 as an assistant professor of medicine and epidemiology. She moved to the University of Michigan as an associate professor of epidemiology in 2003 and on to professor of epi there in 2006. While she was at the University of Michigan, she was a research professor in the Institute for Social Research, director of the Robert Wood Johnson Health and Society Scholars Program at Michigan, and served as the director for the Center for Social Epidemiology and Population Health. She became chair of epidemiology at Michigan in 2012. She moved 2 years later to Drexel, 2014, as Dean and Distinguished Professor of Epidemiology in the Dornsife School of Public Health. She's an elected member of the National Academy of Medicine, the American Epidemiologic Society, and the Academy of Behavioral Medicine Research. She is known for her research on the social determinants of population health and the study of how neighborhoods affect health. Her research areas include social epidemiology and health disparities, environmental health effects, urban health, psychosocial factors in health, cardiovascular disease epidemiology, and one of my favorite topics, the use of multi-level methods. Her presentation is entitled Advancing Population Health, 5 Propositions and a Research Agenda. I look forward to this talk, and I'm sure you do. Please now join me in welcoming the 2018 Robert S. Gordon Jr. Lecture Award recipient, Dr. Ana Diez Roux.
Thank you, David, for that very kind introduction. Good afternoon to you all. I'm very honored to be here delivering this lecture to you this afternoon. And what I thought I would do is take advantage of this opportunity to share with you some thoughts and reflections on population health. And what I'd like to do is talk a little bit about, well, what is population health, very briefly, suggest 5 propositions on population health and talk a little bit about what their implications are for research and potentially for policy as well, and then conclude with some thoughts on what you'll see is a pretty broad, but I hope still interesting research agenda. So if we think about population health, there are multiple visions of population health, as I'm sure you know. If we do a quick web search, you'll find a lot of websites that talk about population health and population health management. This has become increasingly common over the past few years. And most of these really are focused on a pretty narrow, what I would call a pretty narrow definition of population health, which is an approach that tracks outcomes of collections of patients in order to assess and improve quality of care and increase cost effectiveness of healthcare interventions. So this is certainly very important, and it's good to see that medicine is thinking about this, but there are also broader ways to think about population health, and here's one example of a definition that has been highly cited. The health outcomes of a group of individuals, including the distribution of such outcomes within the group. And under this conceptualization, population health includes health outcomes, but also patterns of health determinants and policies and interventions that link these two. Now, this broader view of thinking about population health is grounded in even earlier definitions, including this one from the late 1990s, where population health is defined as a conceptual framework for thinking about why some populations are healthier than others, as well as the policy development, research agenda, and resource allocation that flow from this framework. So if we think about this, this means that population health really encompasses factors at multiple levels, from society and social and economic policies all the way to genetics and individual level biology. Now, if we think about, if our mission is to improve the health of populations, what do we really need to do in terms of the grand scheme of things? And I would argue there are two big things we need to do. One is shift population patterns, and this harkens back to the work of Diez Roux, which I'm sure many of you are familiar with, this idea of modifying whole distributions of risk factors, and that means acting at a pretty macro level, which are the drivers of these distributions, and also, of course, lowering risk in those at highest risk. And also, in addition to these shifting population patterns, I think the other big thing that we need to address if we want to improve population health in a significant way is to reduce inequities. Reduce inequities in health by class, by race, ethnicity, by gender, by place. So the population health approach, or the population health framework, therefore, if we want to do these two critical things, requires us to think about multiple levels of organization, and critically that means moving beyond healthcare. Also, taking seriously the idea of social biological interactions, the notion that we can't understand social patterning of health without understanding biology, but we can't understand, in many cases, how biology works if we don't understand context, and that context includes how people are related to each other in society. An explicit concern with health inequities, and translation broadly defined. And I'll come back to what I mean by that towards the end. So these are four things that I think characterize a broad population health approach. So under this view, population health certainly encompasses the individual level factors within the purview of classical clinical care, but broadens them to consider upstream determinants. And I think this is important not only to effective interventions or policy, but also, I would argue, to comprehensive ideologic understanding of basic processes driving health. So 5 propositions that I'd like to share with you about population health and talk a little bit about their implications is, first, that there are big population health questions that we do not have answers to. Second, that a biomedical approach alone is often not sufficient. Third, the complementary nature of observation and intervention. Fourth, complexity is everywhere and could explain some of the inconsistencies that we see in research findings. And fifth, the importance of bridging multiple types of evidence. And I'm going to talk about each of these a little bit in turn. Big questions with no answers. So I'd like to share with you a few big questions. I'm sure you may have others, but one big question is why the US does so poorly in health. This is an example taken from a report that the Institute of Medicine, now National Academy of Medicine, put out a few years ago, showing that US life expectancy is low at every age, and in both sexes, the rank is never better than 15th out of 17th until age 75. This is among high-income countries. So quite poor performance. And this is across the board for multiple different causes of death. In fact, for every cause of death examined, young Americans lost more years of life before age 50 than did young people in peer high-income countries. So this is quite pervasive, and it affects not only mortality, but also a range of measures of morbidity. So this is one big question, and the truth is we don't have good answers to why this pattern exists. Another big question is the spatial heterogeneity and race heterogeneity, in this case, in life expectancy. This is taken from a paper that also got a lot of press a number of years ago, the 8 Americas, showing these dramatic differences, regional differences in life expectancy. Very, very big differences, as you can see on the right, 10-year differences or more. This is another recent example, the increasing death rate among young adults, which initially was described primarily for white Americans living in rural areas, but now we know that it's actually happening across a range of race and ethnic groups and not restricted only to rural areas. So why are these patterns happening? I would argue that in order to really understand what's happening, we need to take this broad population health approach. Another example has to do with things like differences in hypertension. These very big race differences in hypertension that we see, the social factors don't fully explain them, at least the way we're looking at them. Genetics doesn't fully explain them, at least the way we're looking at them either. And so what's going on here? How can we move beyond the approaches that we've been using to really integrate in order to really shed light on the drivers of some of these differences? And not only in the prevalence, but also in things like control of high blood pressure. Very, very big race differences, for which we still have no compelling explanations. My second proposition is that in understanding these big questions and many other questions, potentially in population health as well, the biomedical approach is often not sufficient. And how do we move beyond biomedicine? And I'd like to describe two ways, two examples. There may be other ways, but these are two examples. One has to do with enhancing understanding by integrating social context with genes and epigenetics. And the second has to do with enhancing actions and interventions by integrating social context into clinical care. And I'm going to show you a few examples of what I mean by this. This is one example of a paper that one of my former doctoral students, Paul Christine, worked on, looking at the interactions between a genetic risk score for diabetes and neighborhood food and physical activity environments. And so what this figure shows is that if we look at the independent effects of having above the median diabetes genetic risk score and above the median adverse neighborhood environments, we see that the combined effect of having both factors is more than what we would have predicted from their independent effects. So this is what defines, both on an additive and on a multiplicative scale, this is what defines interaction of effect modification. So, if these findings, of course, are replicated, what this would suggest is that in order to understand both the effects of the genetic risk score and the effects of the neighborhoods, we need to really look at them both together. And that the environment, in looking at gene-bioenvironment interactions, should encompass more than the traditional age and gender, for example, and behaviors, to also think about things in the real external environments, such as neighborhood context. Another example, of course, is epigenetics. This is an early paper showing how identical twins diverged over time in their epigenetic profiles, and clearly this means that there are environmental influences on these epigenetic markers. But we could get more specific than this. This is an example of a conceptual model from a project led by Jen Smith that was recently funded, looking at the relationships between socioeconomic status and neighborhood characteristics, DNA methylation, and gene expression in relation to cardiovascular risk. And just to show you a few preliminary examples from this kind of work, this is an example looking at the relationship between various social factors, childhood socioeconomic status, adult socioeconomic status, neighborhood social environment, and neighborhood disadvantage in relation to methylation of stress reactivity and inflammation related genes. And what we observed is that there's a patterning of methylation associated with these exposures. And this patterning is in turn related to gene expression. So of course, what this means, we need, in terms of the disease risk, is something that needs to be further investigated, but it appears that we can detect some signals of the social environment on epigenetic markers. So in order to fully understand the role of epigenetics as a mediator of other factors, we really need to think about social factors in interaction with these processes. The next way of thinking, moving beyond biomedicine that I wanted to touch on has to do with integrating social context into clinical care. And you may have heard about this because there's been a lot of interest in thinking about, well, can the addition of psychosocial and social factors be used into clinical practice, or electronic health records be used to enhance patient care? And this is just some examples of news items about this. There was a report from the Institute of Medicine as well a couple of years ago that recommended a series of domains that might be considered for systematic inclusion into electronic health records that might be useful in terms of potentially provide benefits to clinical medicine in terms of greater precision in diagnoses and treatment, identifying important factors, referrals, and tailoring and targeting of interventions in clinical research, and also potentially provide benefits to public health through improved the use of electronic health records linked to these factors for surveillance, etiologic research, and policy evaluation. So there have been a number of publications that have done, still pretty simple things to add usually socioeconomic information based on neighborhoods to electronic health records in order to see the added value of this information in terms of prediction or in terms of risk prediction, in terms of outcomes, for example. And of course, there have been there's been interest in thinking about this as an integrated data resource. One example to create, on the left there, to create a platform that integrates geographic data with electronic health record data, and of course the interest in the precision medicine initiative of linking genetic and other individual level patient data to social and environment data. There are a number of challenges to this, of course. The first is measurement. Systematic measurement of these social and environmental constructs is very challenging. And also making sure the measurements are meaningful in the sense that they're really capturing the constructs that we think are relevant. There are questions about the real utility of this to clinical practice. What is really the added value of having this information? What is the value for research? There's the concern about selection bias potentially, which obviously depending on the size of the cohorts, that there may be some amelioration of that, but it's still a concern for many outcomes. And of course, adverse consequences potentially related to stereotyping patients because of the information that's collected and whether that's going to influence the way clinicians perceive patients and the decisions that they make in ways that are not necessarily better for patients. So a number of challenges, I think, that need to be addressed as we think about this. The third proposition that I wanted to share with you is the complementary nature of observation and intervention. And I think this is really important because I think we tend to think of observation and intervention as two completely separate things when in fact they're not. So the traditional observational approach to research, which is what a lot of epidemiology is founded on, is this idea that we observe associations, we infer causes from that observation, we propose interventions based on those inferred causes, and then we evaluate. This is sort of the traditional paradigm. But there are, of course, many challenges in drawing policy-relevant conclusions from this circuit, from these observational studies, which you are, I'm sure, familiar with. Just the basic challenge of causal inference from observational data and the possibility of incorrect causal inferences, cherry-picking, only the positive stuff gets published, the importance of replication and the difficulty in replication, particularly when different kinds of measures are used. Also the fact that particularly especially when we're looking at things like social determinants, we're often looking at causes that are very distal. with long latency periods and many intervening steps. So this makes the observational approach particularly challenging. And so this has raised questions about, well, and in addition, I would say, are the factors that we examine in observational studies really policy relevant? Are we even looking at the right factors? And there has been quite a bit of debate on this in the literature. These are a few quotes. At the top there, a quote from Sandro Galea saying, you know, practice academic epidemiology now spends most of its time concerned with identifying the causes and distributions of disease in human populations, and far less of its time and imagination asking how we might improve population health. Or with respect to health inequalities, we too often have the right answers to the wrong questions. Or researchers might improve the likelihood of their research having a wider policy impact by focusing less on describing the problem and more on ways to solve it. So this suggests that even if we were able to overcome the limits of observational studies in terms of drawing causal inference, we're just not looking at the relevant factors in terms of intervening. So it really suggests that, yeah, even if we're doing this piece right, maybe here we have a problem because the factors that we're looking at don't allow translation into intervention. What is the intervention that arises from that study? So what can we do to increase the relevance of observational population health research for policy? Well, of course, we can focus the research on specific policies or interventions. So the causal factors that we look at are the policies or interventions themselves. And we can do this, of course, ideally through randomized trials. Unfortunately, and for many of the factors that might be important in terms of upstream or macro level factors, many times, randomization is not feasible. Or when it's feasible, it may be uninformative regarding the types of policies or interventions that are of greatest interest. So the kinds of things that were most interesting might not be possible to randomize. And then, you know, the other option, of course, is randomized experiments, natural experiments. And of course, this may be a way out if the policies of interest have been implemented and if the time lags are reasonable, because we have to be able to detect things in relatively short time lags, and if appropriate counterfactuals can be identified. So unfortunately, these two conditions are sometimes not possible to meet. So we can't do randomized trials, or the ones we can do, like the moving to opportunity experiment, which I'll talk about later in terms of randomized people to move out of poor neighborhoods to less poor neighborhoods. It doesn't inform the kinds of neighborhood level interventions that we might be most interested in. Or it may be difficult to identify natural experiments. So another option is to refine the observational work. Are there ways that we can refine the observational studies? There's been a lot of recent discussion in the field on really improving, utilizing quantitative counterfactual theory to improve both the design and the analysis of observational studies. And so pushing towards a crisper definition of the treatment, and under this this rigorous application of quantitative counterfactual theory, the only causes that are truly identifiable are, quote, practicable, well-defined interventions. And so this has generated quite a bit of debate on the field on, well, what kinds of things under this paradigm are really identifiable causes? There have been multiple papers, methodologic papers discussing this very, quite a fundamental issue in terms of what factors can really be identified as causes in observational studies in a meaningful way. And so what are the implications of this debate for population health research? Many of the causes that we're interested in, I would argue, are social or environmental causes that are macro or distal. As I said, they're not easily reducible to a single intervention. And the definition of what's practicable can be problematic. What do we mean exactly by practicable? Is it a policy that could be implemented but no one has implemented, or what's the definition? And also, if only well-defined and, quote, practicable interventions can be identified as causes, can many of the social factors we study even be thought of as causes? Can we think of, socioeconomic position as a cause or discrimination as a cause? And if that's the case, if we can't, then that would mean that our policy intervention recommendations can only be based on well-defined practicable interventions. And of course, this has generated quite a bit of concern among folks interested in these macro or more social determinants. Now, I think there's, a little bit of a way out of this dilemma, this debate. And I put up a couple of quotes here from a commentary that I thought was particularly insightful. And it says, the authors, Gleamore and Gleamore, said there's a counterfactual interventionist notion of causation and a historical, or more exactly, ideological notion. So the first one is of interest when one is designing a public policy to intervene and solve a problem, but then the historical, or more exactly, ideological notion is often of use when one is identifying a problem to solve. And so ideological causation does not always direct us to practicable interventions directly. That thing that I showed you doesn't always happen. For that, we need to focus on causes that are feasibly and ethically manipulable. But it can provide us with the rationale for wanting to change outcomes. And I think this is really important. And in fact, one could think about questions that are about ideology and questions that are about intervention. And the intervention questions are more specifically about these practicable, well-defined interventions. But I would argue that there's also an intersection between these two types of questions. Let me tell you a little bit more concretely what I mean. We could create sort of a gradation of causes that go from broad antecedents leading to multiple causal pathways, to specific characteristics, to a hypothetical intervention, to a practicable intervention, that is one that we think we can do now based on the current context, to a practicable intervention under specific circumstances. And as we move up in this list, the breadth of the causal question increases, and as we move down, the specification of the process becomes greater. Let me give you an example. Socioeconomic position, broad antecedent leading to multiple causal pathways. Specific characteristic, education. A hypothetical intervention, increase years of education. A practicable intervention, provide economic incentive to continue education. And a practical intervention under specific circumstances, provide economic incentive to continue education to students in community colleges. So this is really a continuum where ideology, we go from ideology broadly defined to what's really implementation research at the more specific end. So this is why I think thinking about this complementary nature of observational ideologic research and intervention research is useful, and moving beyond this slightly artificial dichotomy, I would argue, between these two things. And I'll return to this idea at the end when I talk about different kinds of evidence that might be relevant for population health. The fourth proposition I wanted to talk to you about is the idea that complexity is everywhere. And let me give you, very schematic, made-up examples, but that I hopefully will be helpful. So if we think about genes and the environment, let's imagine there are certain genetic factors that predispose people to be more physically active. I'm sure if they haven't been found yet, at some point they will be found. There's ancestry and, of course, parental genes. Parental genes are, of course, related to the genes of the offspring. Ancestry may be correlated with genetic factors. There's culture. There are family norms that may modify the effect of genetic factors. And also there's a feedback loop. Family norms affect physical activity, and physical activity in turn reinforces certain norms. And there are environments and peer groups that play a similar role. So here, isolating the effect of the gene or isolating the effect of the family norms is quite artificial, because it's hard to understand the effect of this factor without understanding the system in which this factor is embedded. Another example, the impact of neighborhoods in health, an area that my group has worked in quite a bit. So personal resources and potentially preferences affect residential location. This may be modulated by discrimination. Residential location affects area, material, social, and advocacy resources, which in turn may reinforce residential segregation. These area resources affect the location of stores and physical activity resources, which in turn reinforce some of these social and physical characteristics. These location of resources may affect health behavior, potentially diet, physical activity behaviors, but then the behaviors of people in the neighborhood affect the resources there as well through a reinforcing mechanism. And then we have other factors like stressors and coping mechanisms that may play modulating roles as well. So similarly here, we have a system. And these systems, the presence of these systems can give rise to what's been called policy resistance, which is the tendency for interventions to be defeated by the system's response to the intervention itself, or when obvious solutions fail or even worsen the situation. And I'm sure you can think of examples where this has happened in terms of well-intentioned interventions that have either not worked or even made things worse. So the question this raises, well, these are really dynamic systems. And what I mean by dynamic systems is that systems where there are factors at multiple levels, where there are heterogeneous and interdependent units, people, for example, where there are feedbacks. This idea of endogeneity characterizes all of these systems. Nonlinear effects, this idea that intervening at one place can cause effects much later or distant in space and time. And this notion that you can have multiple paths to the same outcome. So people can get cardiovascular disease through several different pathways. There's not a single pathway. And similarly, the same cause can lead to different outcomes in different people, depending on a range of other circumstances. And this results in this idea of emergent patterns, and that cannot easily be reduced to independent effects. So these emergent patterns are not magical things. They emerge from the functioning of the system. So this, if you think about this probably characterizes a lot of health stuff. So a lot of population health problems. So the question is, should dynamic systems modeling approaches be part of the population health toolkit? And I'll return, what would that mean, practically speaking? And I'll return to this a little bit towards the end. And the fifth proposition has to do with this idea, and this in part because of the complexity, that we really need to bridge multiple sources of evidence to understand the drivers of population health and to figure out what the best interventions might be. And I'm going to show you what I mean through an example from our own work, which has to do with the impact of neighborhoods on cardiovascular disease. So just a very brief introduction, why even focus on neighborhoods? Well, neighborhoods are potentially context for both physical and social exposures that may be relevant to cardiovascular disease and other health outcomes. They have the potential, if we find that they're causally related to outcomes, because people are segregated into neighborhoods based on class and race and ethnicity. If neighborhoods turn out to be important, neighborhood factors could be very important contributors to health disparities. And also because they have potentially public health and policy relevance, because there are specific interventions that we could propose on neighborhoods. In fact, neighborhoods are changing all the time for a variety of reasons, and we could capitalize and promote some of those changes to improve health. So this is what motivated a whole research agenda on neighborhoods and health that began many years ago now. And the first generation was really about secondary data analysis of geographically linked epidemiologic studies using multi-level analysis. And census areas were used as proxies for neighborhoods. And aggregate census socioeconomic characteristics, such as indices of deprivation, were used as very rough proxies for the actual ideologically relevant neighborhood attributes. And this is an example of a paper that we published now many years ago that did just this, looking at the ARIC study, showing that neighborhood disadvantage was associated with increased risk of developing coronary heart disease after controlling, to the extent that we could in an observational study, with socioeconomic factors that we knew sorted people into different neighborhoods. But this, of course, raise many questions about, was this causal? And if so, well, what is it about the areas that's important? Because that's what we need to know in order to intervene. How do these area features exert their effect? What's the spatial scale? What do we mean by neighborhood? It sounds vague. What are the time scales? And most importantly, can we change these characteristics and show an effect? And so this led to what I call Generation 2 studies that really tried to measure do direct measurement of potentially health-relevant neighborhood attributes through surveys, through novel uses of surveys, through GIS and locational data, and through systematic social observation, which is a technique borrowed from sociology, to observe various features of neighborhoods, and then combine the data in appropriate ways to improve the validity and reliability of the neighborhood level measurements. So there's been a lot of development in the measurement aspects. And then these studies looked at both at cross-sectional associations of these more specific neighborhood attributes with proximal health-related factors such as behaviors or stress biomarkers, and also longitudinal studies linking area features to incident disease or to changes in health over time. And this is just an example of some cross-sectional work. This is taken from projects that we have been involved in. But there have been many, many groups working in this area over the past few years, showing that things like access to healthy foods, physical activity resources, walkability are related to the behaviors that you might think they might be related to after controlling for factors related to the sorting of people into neighborhoods, or social environment is related to, for example, things like sleep. Now, of course, this is cross-sectional data. It's observational data. There are many questions about confounding, many questions about reciprocal causation going on, but it's compatible but not demonstrative of a causal effect. There has been some longitudinal work, which of course is an improvement over the cross-sectional data, showing that people who experience a change in their neighborhood environment experience a simultaneous change in some of the things that you think might be related to that environment, using methods like fixed effects models that control for time invariant person level characteristics, or looking at neighborhood factors and incident disease like incident diabetes. So there's been some longitudinal work as well confirming some of these patterns and suggesting that there may be some causal impact going on. However, of course, this work is purely observational, and so it has all the caveats around observational data. The results have not always been consistent. There's been a lack of comparability of many of the neighborhood measures that have been used, and this makes the literature very difficult to summarize. The time frame that we've been able to look at, because of this challenge that many of these things may be operating over very, very long periods, the time frame that we've looked at may not always be the most causally relevant time frame. So we have to make assumptions like that what we measure today is probably what these people have experienced over a longer etiologically relevant period, which may or may not be the case. And so this means that the implications for intervention of this work to many have raised questions. So naturally, the next step in the observation would be to do an experiment, right? Do an experiment and see whether some of these things that we saw observationally, if we randomize two groups, do we see an effect? And there haven't been many experiments, unfortunately. This is one example of an experiment, moving to opportunity experiment, where individuals were randomized to move to a from a poor neighborhood to a less poor neighborhood, and this was mostly women, low-income women, and the study documented improvements in BMI and in indicators of pre-diabetes. However, interestingly, the conclusions of the paper highlight, yes, the opportunity to move from a neighborhood with a high level of poverty to one with a lower level was associated with modest but potentially important reductions in the prevalence of extreme obesity and diabetes, but the mechanisms underlying these associations remain unclear but need further investigation. And this is really important because these mechanisms are going to tell us, well, if we want to do an intervention that's not about moving people, which may not be the feasible intervention in terms of addressing these determinants of health, we really need to understand the mechanisms, because that will tell us on what factors we should be intervening. So this is an example where the experiment motivates new observations. Now, experiments sometimes yield unexpected results. And just to give you a few examples, the same MTO study showed some unfavorable short-term effects in some groups, for example, particularly in young boys in terms of behavioral outcomes. Cash transfer programs, which are programs where people are randomized to receive, low-income families are randomized to receive income transfers, have shown some adverse effects, for example, on BMI. And some neighborhood-level interventions to improve food access have shown little or no effects. So what does this mean? This means that we need to understand why these interventions work and why they don't work, or under what conditions they might work. And this brings us back to this idea of systems, because the effectiveness of an intervention may depend on the broader context of factors within which that intervention is embedded. And so a systems approach is quite different than the traditional paradigm in health research, because it starts with defining the components of the system, which requires abstraction and setting bounds. So it's not about putting everything in, it's about putting what we think is most important in terms of driving the dynamics of the system, developing a formal model in order to simulate, integrate existing knowledge, simulate and explore the functioning of the system, and answer some fundamental questions about dynamics, and then draw conclusions about the drivers of patterns and the plausible impact of interventions under different conditions. So this can give us different kinds of insights into causal processes, test interventions which may not be feasible in the real world, identify new points of interventions that we hadn't even thought of, and also identify and understand the reasons for unexpected effects. And also the type of question changes. So it changes from a question like, is proximity to supermarkets as a proxy for healthy food access associated with better diet after adjustment for individual level SCS, the traditional epidemiologic approach, which I think has been useful, but it doesn't give us a complete answer, to something like, what is the plausible impact of health inequalities of a strategy to subsidize the location of supermarkets under various spatial patterning scenarios? Or from what markers of genetic variability are associated with BMI, do environmental factors modify this relationship? To what are the plausible contributions of gene-environment correlation and gene-environment interaction to BMI differences by income? How is this modified by the degree of contagiousness of behaviors linked to BMI? So the question changes. It becomes a much more nuanced question and much more conditional on other things in the system. And so we have been some attempts to employ these kinds of strategies to the study of neighborhood effects. This is one example that Amy Auchincloss, colleague of mine, led a number of years ago. And I don't have time to get into the details of this, but basically we used agent-based models to explore two questions. One, about whether simple spatial segregation, absence any differences in people's preferences or price differences across neighborhoods, whether the spatial segregation alone was sufficient to create income differences in diet, and then how various interventions, for example, price interventions or health education to modified preferences, could modify these differences. And so, we had a model that included households and stores. Assumptions, of course, are in the model. The model, however, integrates all available information, and then the model can be used to look at how income differentials change under different scenarios. So, of course, there are many assumptions built into this approach. There are issues about, do we have the data to inform these kinds of models? When does the model yield new insights that you wouldn't have predicted from what you already put into the model? And often this raises more, in the process of developing these models, both conceptually and in terms of the operationalization, we realize all the gaps we have in knowledge, things that we really don't know, that then we have to go back and do better observation or better experiments to understand, so that then we can improve the model. And so, the systems modeling, in fact, feeds back into the need for experiments and observations. And then, of course, in public health and health generally, there's often action that we have to take, even in the face of incomplete evidence sometimes, because we have to. Returning to the neighborhood example, these are some examples of actual policies or interventions that, for example, increased access to healthy foods in food deserts. And you can see that sometimes the results were positive, sometimes they weren't. And so this is a situation where it's the simple evaluation of action, policies that were implemented, can also suggest new questions that we need to go back to in observational studies and experiments or incorporate into systems modeling. So I would argue that really we have an evidence-generating system and that we have to think more about this sort of quadrangulation of evidence as a way to enhance our ability to understand these very complex population health problems. That a single approach is not going to be sufficient. And we're not that used to doing this kind of integration, I think. So in the few minutes that I have left, and sort of building on these 5 propositions, what I'd like to do is share with you sort of a broad research agenda to advance population health research. And the first area that I'd like to say a few words about is ideologic research. I think there's still a lot to learn in terms of etiology, but etiology in the broad sense, etiology in terms of linking health and health disparities to distal and upstream determinants. I think we have a lot of good information. Some of it is more descriptive than causal, and I think there are ways that we can use methods for improved causal inference. There's been a lot of development in the field over the past few years in thinking about this. Integration of new types of data that we have not brought together before, electronic health record data, the very large variety of georeferenced data, among social media data. I mean, there are incredible opportunities to think creatively about how we can bring new data to bear on this. Incorporating this notion of feedbacks and dependencies, so this systems thinking and systems tools into this etiologic research, particularly of these more distal kinds of factors. And improved synthesis and meta-analysis. I think in this area, we don't do a very good job at all of synthesizing our findings. And there are complicated reasons for that include the fact that we're often measuring very complicated things, and therefore the measures are difficult to harmonize. However, I think it's very important that we think about ways that we can either post facto harmonize or harmonize more going forward so that we can synthesize this body of work more effectively, because otherwise we often end up throwing up our hands and saying, well, we don't know, that all these findings are all very different and we can't really summarize them. And I think this is a really big challenge for the world of social determinants in particular. And then cross-context comparisons. I think we can learn a lot from comparisons across countries, across regions, across cities, and we don't really capitalize on that as much as we should in understanding etiology. For example, race differences in things like hypertension in the US are not invariant over space. They vary. Why do they vary? What are the factors that cause them to be bigger in some places and smaller in other places? These are the kinds of questions that we can only answer if we do regional comparisons or even cross-country comparisons. Another area of research is mechanistic understanding. And I think there's still value to sometimes you may argue, well, if we know the distal cause, why do we need to understand the mechanism? I think there's still value to some mechanistic research, particularly if it helps to confirm or legitimize distal causes by being able to articulate the proximal mechanisms through which those distal causes operate. Sometimes, maybe we have observational data on the distal causes. We're not sure whether we think, skeptics may argue that that's not causal. If we can articulate the specific mechanism, it strengthens the causal argument. And here, I think, is where the social biology interface, the kinds of things looking at social influences on epigenetic markers or gene expression, I think can be particularly useful. Also, this idea of what I call sort of complex mediation. We tend to think of mediation as a very linear thing. A leads to B, B leads to C, C leads to D. But maybe A leads to B, but B interacts with C. Particularly, for example, cardiovascular disease, we think of stress and behaviors as two separate things, as two parts of the mediating pathway. But in fact, those things probably reinforce each other, because stress affects behaviors and behaviors affect stress. And we're not really looking at that in the analyses that we're looking at. For that, we need to really think about synergisms, feedbacks, context dependency when we're understanding mediation. And then I think another mediating pathway that we have not focused on so much, particularly from the point of view of social determinants, has been healthcare. And I think, for good reason, there has been an emphasis on focusing on things that are outside the healthcare system, because those things perhaps were not as, they didn't receive as much attention in some cases under the more traditional biomedical paradigm. But I think it also is important to think about healthcare, access to healthcare, quality of healthcare as a mediator as well of some of these more distal effects. And so I think it's nice to see this sort of interest within the clinical world on social determinants on health, on incorporating information outside, about the social and physical context that the patient lives in into clinical research. The third area where I think there's a lot of research opportunity is policy evaluation. And really, this is about evaluating the health impact of policies both within and outside healthcare. And I think broadening the range of policies that we look at, education policy, taxation policy, urban planning, social policy. And this is of course not easy to do, but I think with increasing data availability and increasing data that we have, there's possibility for doing creative linkages that would allow us to look at this pretty rigorously. Broaden the tools, so of course natural experiments, also some of the systems modeling approaches that I talked about, and also interactions between different types of policies. So this idea that the impact of a healthcare intervention, so a patient-oriented intervention to improve blood pressure control, may be modified by what's happening in the patient's neighborhood or context, or something that the city where the patient lives has been implemented, for example, in terms of salt or in terms of sugar-sweetened beverage taxes, et cetera. So looking at the interactions between different kinds of interventions, patient-oriented interventions and more environmental or broad policy interventions. That might help us understand under what conditions some of the individual targeted or patient-oriented interventions work and under what conditions they may not work as well. And also, particularly the impact of policies on disparities. I think this is an area where there hasn't been that much work, and I think it's a critically important area because, as we know, there may be interventions and policies that increase disparities. And so thinking about disparities themselves as an outcome is also very important, and an area where there's opportunity for more research. And the fourth area is implementation research, and I know this is an area that has received increasing interest here at NIH, but particularly disparities-focused implementation research. So, why do some interventions not work in certain groups? What factors influence the adoption of proven interventions in certain population groups? What structural factors affect that? Things about the healthcare system. What perceptual factors, things about a doctor's perception of whether this patient is going to benefit or not. Factors influence the performance of proven interventions in different population groups. This is true effect modification in the epidemiologic sense, but why? Why do some interventions work in some groups but not others? That, in a way, is, as I said before, etiologic understanding too, because it's about understanding how context modifies the effect of another factor. And implementation science beyond the clinic. And I think this is very important. A narrow view of implementation science is really about, this is a typical definition, it's about scientific study of methods to promote the systematic update of proven clinical treatments, which is very important, I think. But there's also a broader way of thinking about implementation that has to do with when, how, and why is research about population health translated into policies in general. What are the perceptions about the causes of health or ill health among the public and policymakers? What drives those perceptions? Because that's critical to determining what policy actions are prioritized or supported by the public. What's the process of communicating and understanding evidence about drivers of population health and health disparities? This is more qualitative research about understanding how the evidence that we can get out there is understood and incorporated. And this is an example of a paper published by a colleague of mine, Jonathan Pirtle, just recently, where he led a survey of health commissioners and mayors of cities, asking them some very simple questions. For example, do you agree with the statement that health disparities exist in my city? And do you agree with the statement city policies can have an impact on health disparities? And as you can see, a lot of the, not all of them, but a large majority of mayors and health commissioners either agreed or strongly agreed with the statement that health disparities exist in my city, and yet responses to whether city policies can have an impact on health disparities was much more mixed. So what's going on here? What's the understanding of policies that these mayors and health commissioners have, and what can we do to enhance the use of the evidence that we have about health disparities and policies by these leaders? So to finish up, these are my 5 propositions. They're big population health questions that we don't have answers to. Biomedical approach is often not sufficient alone. Complementary nature of observation and intervention. Complexity is everywhere and could explain inconsistencies, and bridging the need really to take seriously the idea that we need to really bridge different types of evidence. And this, of course, has implications for the kinds of research that's supported and encouraged. And in summary, population health problems and health inequities, which are an integral part of population health problems, as I said, are big, complex problems. And I think there's an extraordinary opportunity today for integration of social, environmental, behavior, and biologic factors and new data to help us shed better light on the drivers of population health. Integration of different types of evidence and analytical tools in ways that go beyond the approach, what we've been doing up to now. A new way of thinking about the relations between ideologic research, implementation science, and policy evaluation is really interrelated. And systems thinking, I think, as an organizing framework. This isn't necessarily about using systems models for everything, not at all. There are many caveats and many there are situations when systems modeling is useful or is not useful. But I think that systems thinking, this perspective of thinking systemically, I think can be very informative and helpful in framing questions and also the evidence that we have. So just to finish up, this is a quote that I like a lot from some Forrester, who some argue is sort of father of complex systems thinking. And he says, in the complex system, causes are usually found not in prior events, but in the structure and policies of the system. And I think this is the challenge that we face in population health, that the cause is not a prior event, but something about the way the system is organized. And so this is our challenge as researchers, to really figure out ways in which we can understand the functioning of that system so that we can shift it to move in a more health-producing direction. And I'd just like to thank many, many people. I'm sure there are many people on this list who are not on this list who should be on it, but these are many collaborators and colleagues I've had over the years who've contributed to some of the work that I showed you today, and of course, funding from NHLBI, NIMHD, OBSSR, and the Robert Wood Johnson Foundation, among others. So thank you very much, and I look forward to your comments or questions.
I have 2 microphones set up, so I encourage people to step up to the microphones and ask questions.
Well, congratulations for looking at the complex issues of healthcare. So what you said makes sense, but it is below the head level.
It is what? I'm sorry?
Below the head level. So when it comes to mental health, drug abuse, and gun violence, we know the issues and we know what should be done, but there is a reluctance. So in those cases, all these hypotheses and all these conjectures and how to approach them, it should be working, but it doesn't. And also there's a cost issue which you did not mention at all, because all these things cost money. So how do you deal with at least the issues of gun violence, say?
Well, you're alluding to another big issue that I did not talk about, obviously, which is the fact that often we have evidence to support certain kinds of policies or actions, but evidence is not the only thing that affects what's done, obviously. It's much more complicated than that. It would be very naive to think that decisions about policy are made only based on evidence or lack of evidence. There are a whole bunch of other factors that are influencing, and I think this is part of the debate that we engage in as scientists, but also as individuals and as citizens, in terms of creating the conditions so that what we think are the right policies are implemented. But it has to do with many complicated social, economic, and political issues. So I think you're right, and does not address that. It's a whole other very important issue.
Yeah, but then when the question comes, the funding I heard has been completely cut out from the issues of surveying gun violence, looking at the issues and how to intervene. So again, there is a significant issue that is not tackled, and there is a reluctance. So I guess somebody has to stand up with some courage and attack. And
Yes,
thank you
you're
and
right.
good luck.
Thank you.
One of the things that you are proposing, I think, is to, at least this was the way I wrote it down, you can correct me if I didn't get this right, spend less time just observing and more time intervening. Would you say that's a fair?
Well, I think I'm not. I think what the point I was trying to make is that we need to do both, and that we can learn about the potential for interventions from observations that are well analyzed, and that we can learn about etiology from observing the impact of interventions. I think we need both. I think there's some kinds of questions for which we still need, the only way we're going to be able to answer them is by doing better, more rigorous observations. And there's some questions in which, yes, we should intervene, but make sure that we're evaluating those interventions in ways that help inform our etiologic understanding in addition to the impact of that specific intervention.
Right. I also heard you arguing for using observational methods to evaluate interventions more than perhaps we do. This combination of observational studies, modeling, and experimentation, a virtual cycle, if you will, that you were describing, is an intriguing one, because many of us tend to think of observation, then intervention, maybe a little more observation than intervention, but it's yours seems to be a more systematic and organized approach.
Well, I think that these three things, observation, experimentation, and modeling, really should be seen as interrelated and reinforcing each other. That it's not a linear pathway, from observation to intervention. I think thinking about it that way causes us to lose opportunities. So yes, I think you captured what I was trying to say.
Hi. In your opinion, do you think we need different standards of scientific rigor for systems in which there are no truly independent variables, like the systems that you're describing?
Do I think we need different
standards of scientific rigor? Because that's a big discussion we're having right now at NIH about scientific rigor and designing cohorts in such a way that you get statistically significant results and things like that. But in a system like you're describing, where there really are no truly independent variables, the question is, do you need a totally different kind of math for that, or do you apply the same math differently?
Well, I think that's a very, very good question that you're raising. I think we should always aspire to the maximum scientific rigor, whatever we're doing. However, we should not assume that the only scientific rigor is a randomized clinical trial. There are ways to do rigorous science that involves observation, or that involves systems modeling, or that involves experimentation. So there's no, scientific rigor is not only an experiment.
Right. Thank you.
And in fact, sometimes we can be misled by the results of experiments, or we may not be able to explore the most important questions using experiments. So if we really want to take seriously improving population health, we need to broaden the set of tools that we're using, and of course use them rigorously, absolutely. All of them can be used rigorously or not rigorously. That's not the tool itself, it's how it's used.
Thanks very much. You gave us an awful lot to think about of things we need to work on. Can I ask you to just speculate on how grants should be packaged that would make this work move forward? I mean, we have a lot of mechanisms, but traditionally the most prestigious and most of our money is going into R01s, discrete questions, 5-year max, and the rest. How does this fit with what you see as the research agenda?
Well, I think, you know, the system, the sort of investigator-driven award system, I think has many benefits, and I think it has yielded, you know, very important work. At the same time, I think it does incentivize a certain type of research, right? And it incentivizes research that is very narrowly focused, that builds, you know, is not super risky, something that, you know, that the investigator is quite confident they can do and deliver on. In fact, that's what they were evaluated on in part. It doesn't encourage exploration of new methods as much. It doesn't encourage, you know, working with the real world of very messy data that we have out there. So I think, you know, thinking about other mechanisms, including, you know, other kinds of broader initiative centers or other kinds of infrastructure kinds of awards that will allow building capacity to do this broader, you know, this broader research agenda is I think is really important, because if we don't do it, I think it'll be very difficult to break out of the, you know, the traditional thing that we've been doing for so long. And it really, I think it really incentivizes investigators to keep doing what they're doing over and over again, honestly. And not always. I mean, obviously there are many examples of very innovative research that has been funded using the R1 mechanism, but I think it does have that potential disincentive.
So I'm George Plopper from Booz Allen Hamilton. I'm not with NIH, but I'm here because it's a public presentation. And full disclosure, I'm a cell biologist, not an epidemiologist. But I'm struck by the parallels between the way that you're describing the problems in population biology with the similar problems that cell biologists are dealing with now, treating a tissue as a population and trying to find neighborhoods and all the rest of the patterns. And as I'm following that thread through, I can say that at least in the field of cell biology, some time ago, we hit an inflection point where the more data we gathered, the harder it was to use it. And the consequent response is the data commons and the atlasing. And so because I heard this from you and I don't have a lot of background here, I'm wondering, has that inflection point hit in your field? And if not, do you see it coming? And what do you propose NIH does about it?
The inflection point in terms of having data that we don't know how to...
Yeah, when the return on your data gathering starts to diminish.
I think that's going to happen. I don't know if it's happened already, but it's you know, I think that is a big, you know, thinking... you know, there is an explosion of, you know, data and big data. All those, some of the things that are now called big data are things that we've been doing for a long time. They're just now called big data. But I think there is a risk, which is that sort of that we will stop thinking and just accumulate data and then not really be able to draw any meaningful conclusions from that data. You know, that being said, I think, you know, the idea of, you know, more discovery science and machine learning approaches, I think, can be, you know, an interesting complement to the more sort of traditional hypothesis-driven approach that has characterized most of health research. But at the same time, I do think that we need to be, you know, that there is a danger that that we will just be pooling together a lot of data and really not be able to make a lot of sense out of it, and that some of the data that we pull together will really make no sense, you know. So I think thinking carefully about what we mean by big data and what kinds of data we really want to pool is very important. Yeah.
Thank you.
It's a good, very good point.
Do we have other questions?
Yeah, I'm just curious. You've kind of hit an inflection point, I think, in most of the sciences where big data is kind of overwhelming. But there's a common sense way of dealing with that. And you can go back to ancient societies such as the Roman Empire, which were known for their public health. And they survived quite a long time and did quite well. I'm not sure what their life expectancies were, but I would think that if you have some common sense, rather than go what people used to refer to as the law of diminishing returns, and go back and investigate historical models that seem to work well and use that as a base to kind of come back. Because just mishmashing what you're getting from electronic records and this and that and the other without setting a model and what is possible and what has been accomplished in the past seems to be an exercise in futility. No?
Yeah,
It seems to me if you don't have a model you're shooting for, if you say, for example, we have this neighborhood, this, that, and the other, this is a realistic goal for this neighborhood, and then do your investigation in terms of that. And my other point was just historical models might be of some value. Maybe not, I don't know. But the Romans seem to do it pretty well for quite a long time, eh?
Yeah, yeah. I mean, I think certainly. I mean, I didn't intend to imply that that there's no utility to all these rich data sources that we're able to pull together. I think there's a lot of utility. I think we just have to be smart about using them, and maybe looking at some historical examples may be helpful.
Okay, well, thank you.
I'm going to encourage everyone to join us in the library. We have some refreshments. You can have a chance to talk to Dr. Diez Roux at further link over there, so please join us in the library.
Thank you.